Brilliant. We are live. So we are privileged today to have Dr. Ian McNicol, a leading light in the open air movement, to talk to us about the very same. So Ian, without further ado, let's get going. Why don't you start off by telling us, I guess, the answer to the fundamental question, which is, why should anyone care about open air, and what the hell is it?
It's a great question. So open air, open EHR, it's the same thing. It's just a little bit easier to say open air. Why should people care? Well, I think it's, even if you don't buy the whole story, I think people should look carefully at some of the principles and ideas, both technical and cultural and clinical, that are in there. Because I think the idea, the big idea that underpins open air is the idea of increasingly separating the data from the apps and running one or more federated data stores. We call them clinical data repositories, that essentially are owned by, well, they're not owned by a company. You know, they're owned by, whether it will depend on the environment, but it could be owned by a hospital service or a community, could be owned by a patient. And essentially, these are data stores that stand alone from the applications that work against them, which is completely different to the way that most of the current health services around the world and healthcare apps are structured, where everybody has their own apps with their own data, and we try to get these to talk to each other.
Okay, so that's I think that sounds like a technically sort of proficient answer. I'm going to ask you to back up a bit and explain to the jobbing clinician what could we have that we're not getting at the moment in our day-to-day sort of ward work and seeing patients. What should we have that this is stopping? Because we're already into the kind of the technical weeds, and I'm sure you're right about all of those sort of technical diagnoses. But what's the kind of, what's the fundamental problem that we're addressing here?
Well, I guess there are two issues. First of all, I mean, if you look at the big picture, the way that we as clinicians and if you like, as members of the public, are served by digital health technologies, digital health and care technologies, is pretty poor in comparison to what you'd expect to have in the rest of your life, whether it's banking or other kind of services. So we're lagging behind in health. There are good reasons for that, and it's universal. It's not restricted to any one country. Every single country has the same challenges. If I just take that down to, I think, two key areas. One is usability and fitness for purpose. Now, that's whether you're a clinician, a specialist, a generalist like me, I was a GP, whether you're a patient or a carer. I think the explosion that we've seen in our daily lives is the app. It's the app explosion. And of course, that's, to some extent, that's having it on mobile and having it accessible. But it's also this idea of platform. It's the idea that, as I did when I jumped from iPhone to Android, actually I took a lot of the apps with me because they weren't locked into the iPhone environment. And in fact, when I moved to Android, I kind of cycled through like 3 or 4 different email apps until I got the one that worked the way I wanted to work. That's what we need to get to. We all of us, including patients, do really complex, detailed jobs, and we need the software to meet our needs of doing that job, either individually or more likely in small teams. You know, the team of people around you. And right now you get that with apps. You get that. You know, there's a whole new generation of SMEs very excited about the whole appy environment, but they don't talk to each other. They don't talk to you. They're all individual apps. They don't talk to each other. So then we have another hugely expensive exercise to try to build interoperability. And the premise of open air is, let's stop doing that. You know, we've got to do it. Let's stop doing it dead, because that's where we are. But let's build a better future where we say, right, let's stop, build the apps, get that level of user experience that we all want, but make the apps talk to standardized data stores.
This is such a real problem. I recall this from my own practice when I was still practicing clinically. I was working in a big hospital in central London, and I was getting there from home. I was using bus apps. I was, the travel-based apps. I was also listening to content on Spotify. And then when I walked through the front door of the hospital, suddenly it was like being in the 1990s again. Nothing. Like terminals on desks, and it was. So this is a real problem, and so let's take that to the next steps. And what is it? you guys have essentially a technical innovation. So this is the kind of the real problem. We're going from this sort of like black to white, from having all of these, or the reverse, from having all of these apps and stuff available to us when we're, say, traveling around a big metropolis, to having nothing inside the hospital. So what's the fundamental impediment? What's the technical innovation that needs to be created that you guys identified? And what's that problem that's being solved, or that OpenAIR is supposed to solve?
Yeah, so the fundamental problem, as I see it, is you've got a lot of very talented people, apps developers, who get an idea from a clinician, and typically what will happen is they will go to that, well, maybe one or more clinicians that say, or maybe the other way around, the clinicians go and say, we've got this great idea for an app. The knowledge in their heads of medicine gets transmitted to the developers, because they'll say, right, we want blood pressure and a pulse and a heart rate, and the developers will go, what's a pulse? What do you mean by a pulse? What is that? Not at human level, but in detail. What kind of, is that a numeric? Is a text? Is it does it have units? So there's a whole bunch of knowledge transfer that goes on when you build the tiniest little app. And if you think about how many conversations like that are happening around the world, so it's hugely wasteful of knowledge, resource, and time and effort. And it also ends up that people speak to people like you and I with our clinical hats on, and we give them slightly different answers because you do a different job. Somebody in neurology doing, so you have a different perspective. And we know a lot of this stuff is not evidence-based either. So we just, we quickly make things up, because we think we know what we're doing, but often we don't. And a lot of the time we're working in teams. And you'll know, working with equivalent team members, they have immense knowledge about whether it's nursing practice or physiotherapy or device management that we don't have. It crosses over with our understanding and knowledge. So we've got this immense part of knowledge that keeps going over and over again and doesn't line up because there's no cool way. So the first premise of OpenAIR is, can we find a way of sharing that, reducing the burden, particularly of new entrants to the market? So there's a pre-built libraries of, okay, this is how you do a blood pressure. This is how you do allergies recording. This is how you record a lab test. This is how you do an end-of-life care assessment. Bearing in mind that there is no real solid truths. So this stuff has to be kind of socialized and worked through. You cannot do it by having a top-down committee who go, oh, this is how you do blood pressure. You have to get clinicians on the ground and saying, no, that's actually not what we do. Is what we do reasonable? So at one level, OpenAIR is deeply technical because it's based on some technical standards, but it also has a methodology for getting clinicians to standardize. I mean, by clinicians, I mean broader than it's health and care professionals to start to think about how they can standardize the way they record things in patient records, but in a way that is evolutionary and takes into account the fact that we're all innovating all of the time. So we need to build that in, and it has to be very agile. So all of the stuff that we do is open source, and also it has very much an open source methodology, which is there is actually no pure standard. It's almost like let the good ideas get reused. So it's standardization on a de facto basis rather than Ian McNichol, who's a GP, says it has to be this.
So that's really interesting. So, I mean, maybe that kind of resonates with the sort of Silicon Valley philosophy of, move fast and break things, let people innovate as individuals and stuff. So how does it work in terms of the devil's advocate question would obviously be, well, if we just let people do whatever they want, how do we have oversight of this and make sure that it's all being done appropriately? How does that work?
So part of the OpenAIR community, and the OpenAIR community OpenAIR is a not-for-profit. It's a very small organization in comparison to, say, HR7, the Fire Guys, or to Snowmen. It's very largely funded by commercial companies who believe this is a good thing to do. But a lot of the money, there isn't a huge amount of money, but a lot of the money is to support our international modeling community. So we build, collaboratively, we build these models, we publish them. We have dedicated tooling that allows us to get clinicians and other stakeholders from around the world to comment on the models. So we get that eventually published. And at that point, we're saying to system developers, app developers, we think these models are fit for purpose. We think our medication, at that point, They draw down as many of those little chunks, components, and it is about components. It's Lego bricks. It's not a whole record, and it's not about the UI. None of this is about UI. It's all about the data. Yeah. We then say it's up to developers and maybe regions to say, okay, we want that one, we want that one. No, okay, you've developed an allergies archetype. We call these things archetypes. We've developed an allergies archetype. It doesn't work for us. We're doing something completely different. That's okay. You know, we expect people to choose or not to choose because maybe they're innovating, maybe they're ahead of the curve, or maybe they're down a blind alley. We don't know. Nobody knows for 5 years.
Super interesting. And what incentivizes the clinicians to do that then? So that, I mean, it sounds like a great system where the clinicians are essentially approving the archetypes before they're released and made available, so that the developers can say, okay, this is a validated module or unit. But what's the incentive for clinicians to do this other than, say, altruism? It's mostly altruism. It is mostly people find it interesting. Now, don't get me wrong, this is not a giant community. And in fact, we don't want hundreds of people commenting because it's really impossible for us to. But we get a reasonable number of people from different, particularly from different professional groups, from different angles. It is actually remarkably possible to get engagement. I think we had something like 70 or 80 people from around the world commenting on allergies. And that's probably enough, you know, just to get that breadth of experience. So virtually everybody in that is doing this pro bono, and I do it myself pro bono. Some people are paid by OpenEHR through the funding that comes from companies, but actually very small numbers. Some are paid by national governments who are also signed up to this process. But they will mostly be the people who are building these models and doing the QA on them and running the reviews. So that's where the money goes. It's not so much in the review, the third-party reviewing that happens. Yeah. Sorry. Yeah. Carry on. I was going to say the really clever bit comes after that, which is we have this idea we call clinical data repositories. So these are smart data stores that understand those little fragments of data and can be deployed immediately. So we don't need engineering to do that. We don't have to go, hey, I've got my new COVID data set. I don't have to go to a database engineer or a programmer and say, look, I need this in my database essentially. How long is it going to take? How much is it going to cost? It doesn't work like that. We just deploy these things immediately into what is potentially a very complex data environment. Yeah. And that's the clever bit. So these data stores are written according to a set of specifications, but we don't define, OpenEHR does not define how you do it. That's down to the engineers to make it work, and they work through a standard interface. Brilliant. Okay, cool. I mean, you touched on a really interesting element of the story that I noticed the other day, which is that some governments are now adopting this. So am I correct in thinking that Brazil has adopted this for OpenEHR, or at least? So tell us what's going on in Brazil. How have you managed to get a huge country? So Brazil's an interesting one. Brazil has been interested in OpenEHR for a long time, and it very, in fact, I think officially it did adopt it, and then it unadopted it. Really? Without being in any way rude to Brazil as a country, there are political issues in Brazil that make some of these things challenging. Right. Okay. So maybe can you make the case for, what was the case for Brazil to adopt it? What was the big, from a sort of governmental level, what problems were they going to solve by adopting it? National patient records, I would imagine, for the big ticket items like, I guess some of the ideas that lots of will be around with you, national allergies records, medication records, a data store, other stuff can be put in. But probably the prime example in the world is not a nation, but it's pretty big. So the city of Moscow have moved all of their primary care outpatient services onto OpenEHR. That's been running for at least 10 years. I had the privilege of working there for a while. Scotland have adopted it, Wales, Malta, a lot of interest in England at regional level. I saw that, a lot of NHS. But let's go back to Moscow, if that's okay, briefly. So what kind of benefits have they seen from this? What are they able to do now that they couldn't do before?
integration. So they've essentially all of what would have been. Now, I'm not entirely. They did have IT in Moscow before. It wasn't it wasn't a greenfield site, but it was more like a brownfield site. They had limited stuff, probably many different applications, none of which joined up. They wanted to be able to, communication between clinicians, being able to share patient records across the state. And also one of the big challenges they had was just managing patient demand. So one of the things they built into their implementation was the ability for managers to advise patients to go to that polyclinic on the north side of the city because it's quiet at the moment and you'll get seen. So the guys who run that have got some amazing tools that sit on top of the OpenEHR data repositories and do all sorts of interesting stuff, which is not really part of our story, but the OpenEHR data set and data store facilitates that.
Yeah, but I guess it is a big part of the story of why national healthcare systems are just so difficult to pay for and run, right? These kind of logistical exercises and sort of like essentially load balancing for patient demand.
Exactly.
So that kind of thing's possible on the back of OpenEHR as well, is it?
I guess, yeah. I mean, there are those. Again, if you know what the demand is, if you know who's being seen, if you know why they're being seen. Again, there are data privacy issues. We don't gloss any over of that, But yeah, that's the ability to have at some level have management data, or even if it's like clinical dashboarding data, so more like audit for clinical teams rather than service management. That's really important nowadays. And the problem is it's all largely locked into individual applications and individual vendors, and getting it out and getting it standardized is really difficult. I'll give you an example. I had a call yesterday in a part of England that I won't disclose because they're still in the early stages, but they were talking about care plans. They were talking about trying to make the patient's journey, across a range of services. Let's say somebody with cancer, who is on a journey and is interacting with many different services. And right now, not only interacting with many different applications that these people may or may not have, but often within the applications, a lot of the data is actually locked into individual forms. You've got your MDT form, you've got your nursing assessment form, and we're killing our patients, frankly, certainly making their life miserable because it's not seamless. They get asked the same questions again and again, stuff gets lost, delays in the system. But we're also killing our staff because we've got this burden of data collection, and so much of it is duplicated and erroneous. It's just an end game of Chinese whispers because we've got all this siloed data. And one of the big things that I'm excited about is to be able to rationalize that so that there's a proper data stream, but have all these multiple applications on top. I want all the multiple apps. I don't want one big system. That's the last thing we need. We need the variety of fitting your job, my job, patients' views. And it's getting a coherent data stream that will underpin seamless care across this highly distributed, complex system is where we're.
Yeah, I couldn't agree more.
That's why they've gone down this road in Scotland. So Scotland has adopted OpenEHR as their national strategy, and we're busy working away on these kinds of things.
That's a nationwide adoption, is it?
Nationwide strategic approach. Now, it's very early days, and we can't do this overnight, and we will need to use traditional integration technologies and traditional company approaches for a long time. But we're starting to get more and more small companies engaging. They go, we get this with a bit of help. I know we were chatting earlier about the difficulties of navigating the OpenEHR website, which I'll come back to. And we know we're not as good publicly at explaining to people at that level what it is to work with an OpenEHR CDR. We need to do better as that as a community. But at an individual level, people like me can work with them and say, look, here's what you have to do. And they get it. They find it easy to do. And they also get the commercial, right? Because at one level we're saying, look, we are asking you to share the data which you would think of as your system's business. We want you to share that as essentially a patient-based record. And there's always a little bit of a pause, and they go, oh, hang on a minute, we saw that as our data. But once they play around with it a little while, they realize, well, okay, there's a trade-off here. Yes, I kind of lose my IP at one level,
Yeah.
but I get other people's. I get, this isn't, I get access to data that was collected in a different app, and actually it takes away all the pain of managing the data, because doing that inside your own application with traditional database technologies is really hard.
Yeah.
So
fascinating.
increasingly, we've got, particularly new entrants to the market go, you know what, we quite like this.
Yeah, definitely. We are one of those small companies been looking at it and liking a lot of what we see. What about the 600-pound gorilla? Gorillas in this space, people, Epic and Cerners, and what do they think about you guys? Are you scared of them? Are they irrelevant? Are they dinosaurs?
And I say this in the right, I hope in the right frame, because I know that they do good value. I know that everybody moans about their clinical software, so it's not just you guys. It's a hard thing to do, and I think companies like Epic and Cerner have enormous amounts of skill within those companies. They probably produce right now state-of-the-art software.
Yeah,
and they're not all evil empires.
No,
I mean, there's a bit of that. So that's not the way. But I don't think it's a good idea to put all your eggs in one basket, whether it's healthcare, IT, or anything else. It's monopoly, and it's actually accidental monopoly in some ways, because building these highly integrated, complex systems is hard, and it becomes increasingly difficult for new entrants to get into that space. And again, one of the big interests in the open air space is its ability to facilitate new people coming in, and in a sense, do some of that heavy lifting that companies like Epic and Cerner have got good at, which makes them able to do the stuff they do. If you're a new company coming in, or even a company coming to another country, you've got to build all that again. Yeah. So will Epic and Cerner move to open air? No, probably not. But there are companies, if you like, a little bit lower down the food chain who are going, you know what, we think this is the future. And I'd be remiss to start naming names, but we know that there are some of those sizable companies are starting to think in those terms.
But if you were advising Cerner and Epic, would you be advising them to find a way of adapting to this because this is the future, or is it realistic for them to entrench their position?
I have had some conversations and have had advising them, and there have been some, they're a little less hostile than you might imagine. They get the principles because they're good at this stuff. Of course, the turkeys are not going to vote for Christmas. They're doing very, very well financially. Persuading their boards to make a jump like that. Why would they? What we do see, though, increasingly is the customers going, you know what, we either like Epic or Cerner or Allscripts, but we don't want to give everything to them. So let's set one of these CDRs alongside. We call this the bimodal. It's something that Gartner talks about in Industry Journal, a bimodal approach. You've got a not terribly well loved, maybe big app that's been there forever. Is annoying, but actually you can't afford to get rid of it for all sorts of reasons. It does the big stuff well. The problem is it can't adapt quickly to the new stuff. It can't adapt to COVID coming along or whatever it is that happens next year, or just new ways of delivering care, some of the new ideas like your company's got. How can we facilitate that? Well, why not set a CDR alongside to pick up that new stuff? That actually happens right now.
Right.
But what happens is that clinicians like you and me commission a mate to build an app in Excel or SQL Server or something, and the hospitals end up with like 600 or 700 of these things. We call them systems, which are often really good, but often very badly engineered, completely siloed, and frankly sometimes break the law in terms of data protection requirements. What we want to do is to pick up that energy, enthusiasm, and innovation, but put it in a more integrated, channel it into a situation where it's safe for patients. These apps can talk to each other, and the big system, whether it's Allscripts or Cerner or whoever, that feels like a sustainable model. And let's see what happens. Let's see in 10 or 20 years how Cerner and Epic feel about that. In all honesty, in that time scale, there will be probably no Epic, no Cerner, no OpenAIR, no Fire. You know,
You
all
don't
of these
think
things, it'll all have moved on. You know, you think how
Yeah,
fast.
okay, yeah, sure. Yeah, no, maybe the technologies will supersede one another. I guess the question is though, does Epic and Cerner have a bit of a blockbuster whiff about them, or are they going to manage to adapt? And it'll be super interesting to see how that works out.
I'm not. I mean, obviously, I have skin in this game. I have other people friends who work in the health informatics space who are pretty sure that they're at the high water mark.
Right.
Actually, we just can't afford them. In all honesty, it's too expensive.
Yeah. Cool. So, if to get back down into the trenches, if a clinician is watching this, I don't know, say an ambitious registrar or even an early consultant wanting to carve out a carve out a project or something in this area, how does he get started? Who does he talk to? What page should he go to? How do we get going?
So, I mean, ultimately, this OpenAIR isn't a kind of building project, if you like. We don't build open source, so you can't come to us and say, we're a collaboration of people that want to use a set of technologies and methodologies. So, but there are a few pointers. There's an outfit called the Aperta Foundation in the UK that will kind of reach people and sponsor people who want to go down this road. Okay. I'm always happy to do this individually through my consultancy company, not just as a pro bono evangelical thing, if you like. I want to point people in the right direction. The OpenAIR community has a pretty lively discourse community channel. So if you just look for OpenEHR and discourse, you'll be taken in there.
Okay.
You're very welcome to join up as a formal member. All of the IP is free to anybody. Right. But we do have a formal membership, and that's more about. But it only costs you €15, and it gives you the joy of being able to sack people like me from the board. It's all about. You get to vote, basically. So that's probably the main ways to get started.
Okay. And so that's for a clinician. How about a technical person that's trying to work out what's the first? Say his boss has said to him, we're going to start building. We're going to use OpenAIR as our database. Where does he? And his eyes roll. Obviously, where does he start there?
That's a challenging one right now. So there's a very easy answer, which is if you go on to the OpenAIR website, you'll see a whole bunch of industry partners and industry professionals. So I'm sort of on the professional. Go and have a look and see who fits what you think you might need and start that conversation. It may be not the end of the story. You may go elsewhere. One of the things we're not good at right now, there's a lot of very detailed technical specifications, but it's a bit of a minefield for people to engage with, particularly an SME on the technical side. So we're in the middle of a big strategic review to change the website, get a lot more educational material. So if you like, bear with us while we get that. It's partly just a reflection of where we've been as a community, and we're on to a new phase now. But I'm certainly very happy. We do have access to a thing called the Code for Health platform, which allows us to provide sandbox environments for people who want to play technically. And,
okay, what's that called again, Ian? I think it went quite quickly. What's that box?
It's called the Code for Health platform.
Code for Health platform. Okay.
Again, you'll find it under the Aperta Foundation banner.
Gotcha. And that's APPERTA, is that right? Aperta. Anyone that wants to look that up, fantastic.
Yeah. But again, by all means, contact me directly. I kind of run the thing in the background and provision things and tidy it up. So Ian@freshair.com is my email address. More than happy for people to contact me, or you'll get me on Twitter as well. Probably two other documents for people who want to get more of an overview. There are two documents I'd suggest. One is, again, published by Aperta. It's called Defining the Open Platform. And the other is an EY paper, Ernst & Young paper, whose name might escape me, but we'll try to make that available in one way. Again, it's about the platform approach in health IT. So that's very recently published, and I think is a really, really good overview. It mentions OpenAIR and Fire and all these things. It's not specifically about OpenAIR, but it's about this bigger idea of an open platform approach to building health IT, rather than let's build it all in silos and try to join it up later.
Absolutely. I mean, I think this is super exciting. I came across OpenAIR when I was banging my head against these kind of problems, having to try and work out how can we interact with Epic, how can we interact with Cerner, and eventually I thought somebody must have been doing something about this, and started Googling, and soon came across OpenAIR. So I think a lot of people are thinking in this way, and it's fantastic.
There are ways to interact. Yeah, no, so your FHIR is the way that you interact, but there are probably limits to how far that interaction will go, particularly for novel data sets like yours. So we're saying, let's stop doing that. Let's just build something alongside, rather than trying to make these guys the masters of the universe.
Absolutely. All right, Ian, look, unfortunately, we've come to the end of our half hour. It's been an eye-opener and a pleasure, as always. And I look forward to chatting again. And it's fantastic that you're happy to be contacted by anyone that would be interested in this. It's we've good, brilliant attitude. So yeah, look forward to seeing onward and upward, greater progress and successes for OpenAIR in the future. And thanks for your time.
All right.